gastroenterologist with a special interest in reproductive health, one of the most common questions I have is what kind of information do I give patients and their families when they're starting to think about having a family? We know that patients with Crohn's disease and ulcerative colitis have many chronic symptoms related to their disease, history of surgery related to their disease, and they're also on medications to continue treating their disease and to keep their disease in remission. The first thing I get asked in my clinic when I do counseling for hopefully future mothers is they say to me, Dr. Liang, should I even think about getting pregnant, given I've had this chronic inflammatory condition since I was a child or a teenager or in my early 20s? I'm on multiple medications and I've had surgery. Is this even a possibility? It's really important that if you're thinking about having a family that you involve your gastroenterologist, or more importantly, you don't make assumptions that you shouldn't get pregnant because of your disease. You should really, if you feel comfortable, share that with your physician, your gastroenterologist, so you guys can have the discussion. Due to the genetic nature of Crohn's and colitis, where we know that there are certain genetic mutations that put you at higher risk than the general population of getting Crohn's and colitis, then the obvious question is, will I not pass this disease on to my future children? And I always say to them, in this case, the science actually is very good news. Even though there's a genetic component to getting Crohn's and colitis, it's not the kind of disease where for sure you will transmit it to your children. And you know that because for the most part, most patients actually don't have parents that have Crohn's or colitis. When you have a family history, it does slightly increase your risk, but it's not even anywhere close to 50%. And the good news is most long-term studies of large birth registries that then follow births of children and how they develop into adulthood and then trace it back to a mom or a dad who had a diagnosis of Crohn's or ulcerative colitis show that there really is a very small number of people who ultimately get Crohn's or ulcerative colitis because of their mom or dad having ulcerative colitis or Crohn's. And that number, depending on which research study you read, is anywhere sort of between 3 and 10%. But I've never really seen anything consistently over 10%. So that is a rough estimate, but again, that should be very reassuring to patients and families. The only time I see that number starting to go into double digits is if both patients, meaning, both parents, the mom and the dad, have Crohn's disease or ulcerative colitis. That is a relatively more unique phenomenon, and that instance will probably need a little bit of extra counseling, but it really is good news. So again, we think of inflammatory bowel disease as being hereditary, but not hereditary in any type of what we call high penetrance. So most people will not have children that will have Crohn's or colitis. When you're at the stage where you decide that you may want to try to get pregnant, there are important factors that have to be discussed first. The first is that you should always be in remission. So you know everything you know about your Crohn's disease and ulcerative colitis. And I know for most of you, you know what it's like to be sick. And I always say to patients, well, how would that feel to be sick during a pregnancy or as you're trying to get pregnant? So aiming for remission before pregnancy is really important. And that is why, again, I think it's really important that you talk to your healthcare providers and your gastroenterologists. For example, I just did a clinic last week where I saw 6 patients who were planning on getting pregnant, and 3 of them just weren't in a good state of health. They all had very active disease. So we discussed what that meant. And right now we're going to work on controlling their disease before they get pregnant, because it's really important that when they go into a pregnancy, their disease is as inactive as possible to avoid complications during those 9 months. As I was saying, this has become an emerging topic for many IBD centers because we know so many of our patients are diagnosed during their reproductive years. This is not based on science, but in general, I do tell my patients to be in remission about 3 to 6 months before they start trying to get pregnant, because we know from really good studies that if you get pregnant while your disease is active, a large majority of times that disease will continue to get worse and worse during pregnancy, and potentially then have negative effects on the pregnancy, such as, for example, the baby doesn't grow the way the baby should, or it may precipitate a miscarriage, or it may precipitate a preterm labor. In general, something else that I also point out to patients is that for the most part, and we'll get into specifics, most IBD medications, for the most part, particularly the biologics, so the injectable type drugs, are safe to continue during pregnancy. So again, don't make any decisions without telling your doctors about stopping your Crohn's and colitis medications. Of all the medications that for sure we know needs to be stopped would be a medication called methotrexate. In general, over the last 10 years, there are fewer and fewer patients on this medication called methotrexate, but I'm very, very clear that this is not a medication that can be continued even while you're trying to get pregnant. And really everything else that's a biologic, that's an injectable, so drugs that you're probably heard of before, if not already on it, and I'm just going to give a list of them. So drugs called infliximab, different brand names, Remicade, adalimumab, again, brand name Humira. Some of you may recognize the name vedolizumab, brand name Entyvio, ustekinumab, brand name Celera. Again, these are all injectable drugs, and they have been shown in studies to be generally safe for pregnancy. Now, there are nuances to that. Some of the older biologics we have more information on. Some of the newer biologics that just entered the market the last 5 to 10 years, we have less information on. So this is a general principle. So this doesn't, again, replace the fact that you should speak one-on-one with your physician that's prescribing these medications. But I always say, as a general start, these medications are safe to continue while pregnant. And again, the only one that's not is the drug called methotrexate. So how do I know this? How do I know that it is safe to continue biologics? Well, first of all, if you think about the structure of biologics, these injectable drugs, we can be very reassured that they tend not to want to cross the placenta during the early part of pregnancy. And because they don't cross the placenta in the first or early part of second trimester, they will not cause what we call congenital anomalies. So for example, you hear about these scary things like a congenital heart disease or cleft lip, for example. Those developmental abnormalities happen in the developing fetus during the first trimester. And so when you're on biologics, the good news is they don't cross the placenta when the fetus is forming important structures. So that's something that you do not have to worry about. So in 2022 and soon to be this year, we will have a total of 3 other new drugs that I should probably talk about. They are not biologics, they are small molecules. So one is called Zeposia, one is called Xeljanz, one is called Rinvoq. And these medications, because they are new, we have very limited data on. They're all oral drugs. And for now, we recommend that women do not start them at the time that they are trying to get pregnant. So a very practical example would be if I have a woman in my clinic, I was thinking of starting them on one of these new drugs, but they tell me they're going to get pregnant in the next year or so, I would not start any of those 3 medications. Similarly, if I already had a woman on them, we would counsel about stopping them, getting them on another drug that has a safety record for pregnancy before trying to get pregnant. So similar to what I said about methotrexate, these 3 new drugs I would not use during pregnancy because we have very limited data. Again, going back to that planning before pregnancy, we will advise patients to do also general things that may not be obviously related to their Crohn's or colitis. Those include if you are smoking or drinking alcohol, to stop smoking and drinking alcohol. If you're on other medications, to have that reviewed with your family physician. So medications that are unrelated to the Crohn's and colitis. And specifically, we want to check vitamin levels. So a very common vitamin level that we would check before a woman gets pregnant would be her iron levels, for example, and vitamin D. And depending on those iron levels, we may actually supplement before the patient gets pregnant. So another question patients and their family have is in regards to lactation, breastfeeding, nursing. So the majority of our patients who choose to continue their treatments during pregnancy will also be encouraged to keep their medications during the postpartum stage. And we very much encourage patients, if they decide to breastfeed, because we know there's actually a protective factor. So we know that infants who are breastfed, if you look at general population studies, are actually then, when they're adults or older anyways, less likely to get immune-mediated diseases like Crohn's disease and ulcerative colitis. So for many reasons, we actually really encourage and support moms who want to nurse. If it's not something a mom wants to do, of course, we support the mom's decision. But for those moms that want to do nursing and breastfeed, we very much encourage that. So what science tells us is that the medications that you can safely continue during pregnancy are also safe to continue during nursing. So for example, again, the biologics, if you continue them during pregnancy, we would encourage you to continue them during nursing. And again, the medication we would stop anyways would be the medication called methotrexate. The other thought, though, quite rightly, is a lot of patients will say, you know what, I remember when I first started these biologics, my doctor counseled me that I may be at high risk of infection. So how is that possible then if later on in pregnancy, the biologics start crossing the placenta into the developing fetus, and the baby is then born with these drugs in their body? How are they going to be okay if I had to be worried about infections? And that's actually a really, really valid concern. What we do know is that we have done research that have followed newborns into various stages of their life. And what we can say is, thank goodness, the immune system has different pathways to protect us against infection. So again, going back to basic principles, yes, the biologics do get into the baby in the second half of pregnancy. And yes, the babies are born with biologics detectable in their body. But because your immune system has different layers of protection, we have found in these studies that the infants in their first 3 to 6 months of life are not at higher risk of infection than, for example, babies born to moms that were on no medications. So though it's theoretically possible these babies are at higher risk of infections, in fact, the data tells us that they are just as healthy. So that's very reassuring. Again, we don't expect you to watch this video and be 100% reassured. We want you to go and speak to your gastroenterologist. But again, this is just outlining basic principles that we want patients to have access to when they're even thinking about starting this journey. And then finally, in terms of vaccination. So after 9 months, baby's been born, you bring a healthy baby home. The final question I get in my pregnancy clinic is, can my babies get the usual vaccines? And the data is yes. And in fact, we have more and more emerging data to support that. So again, this video is not to go over every detail of pregnancy and IBD. It's being given to give you sort of a framework to sort of go over basic principles so that you can now go to your own gastroenterologist and ask your own questions. But I do want to be very clear, for those of you who are thinking about starting a family, there are very few cases where we would say, no, you shouldn't, based on your disease. In fact, I can't think of one case in the last 15 years I've ever said to someone with Crohn's and colitis, no, I don't think you should have a child if that's something you want. The second principle is, in general, most medications are safe, so don't go ahead and stop them without consulting your healthcare team, specifically your gastroenterologist. Number three, we have done good research to show that babies exposed to the majority of our medications are born very healthy. And finally, I cannot stress more, it is very important for your disease to be in remission before you start trying to get pregnant. So hopefully the last 10-15 minutes has been a helpful overview of things to think about as you're starting to consider planning a family.